Welcome to episode 24 of the Pro PA podcast. I'm your host, Professor G. Today, we're diving into a critical topic, Acute Respiratory Distress Syndrome, or ARDS. ARDS is a life-threatening condition that every PA needs to be familiar with, especially in ICU and emergency settings. In this episode, we'll cover the basics, the pathophys, clinical presentation, diagnosis and workup, management overview. We'll take a look at the book med versus the street med, and of course, vignette-style questions to reinforce your knowledge. Let's get started. First, let's look at the kinder patho. What is ARDS and how does it develop? ARDS, or Acute Respiratory Distress Syndrome, is severe and a form of non-cardiogenic pulmonary edema, and this is caused by inflammation and increased capillary permeability in the lungs. ARDS leads to acute hypoxemic respiratory failure and requires urgent recognition and management. So, how does ARDS develop? Well, first off, it's from inflammation. So, there is some sort of inciting event such as sepsis, trauma, or pneumonia, and this triggers a massive inflammatory response in the lungs. We get cytokines and immune cells, and they flood the alveoli. Then we have an increased capillary permeability, and this inflammation is what damages that alveolar-capillary barrier, and it allows fluid, proteins, and even immune cells to leak into that alveoli. Then we get the alveolar collapse. So with that fluid buildup and the surfactant dysfunction, the alveoli collapse, and we call this atelectasis, and this impairs oxygen exchange. And last but not least, we get hypoxemia, and this is the hallmark of ARDS. It is caused by that ventilation perfusion mismatch and shunting of blood through poorly ventilated lung regions. And so ARDS progresses through 3 stages essentially. First off, there is the exudative phase, and this is usually from day 0 to 7. And this is where you have that alveolar edema and inflammatory infiltrates that dominate. Then you move on to that proliferative phase, which is about days 7 through 21, which is where the alveolar repair begins, but some inflammation persists. And 3, the fibrotic phase, and this is usually after about 21 days. And in severe cases, fibrosis will develop, leading to long-term lung damage and reduced compliance. So I think the patho, even though this is probably a little more than kinder patho, is really important in understanding ARDS and how it develops so rapidly and why it can be such a high mortality rate. Now, let's look at the different causes of ARDS. Remember, ARDS is a syndrome, so it can't come by itself. It has to be precipitated by something else. And so I like to use the mnemonic SPARTAS, SPARTAS, to remember the common causes. So number 1, we have S, sepsis, and this is the most common cause of ARDS. P, we have pneumonia. A, aspiration, like aspiration of gastric contents. R, respiratory infections, like viral or bacterial infections. T, trauma, so things like chest trauma or burns can cause ARDS. A is going to be acute pancreatitis. And S, shock. Any cause of hypoperfusion can lead to ARDS. Other causes that are not included in this mnemonic are inhaled toxins, near drownings, and transfusion-related acute lung injury. All right, so how do these patients present? Well, the clinical presentation is going to include symptoms of a rapid onset of dyspnea, and this usually happens within 6 to 72 hours after the inciting event. It's going to accompany tachypnea, fatigue, and hypoxemia. And on physical exam, these patients are going to look really, really sick. They might be cyanotic. They might be really struggling to breathe. You could hear crackles or rales in auscultation. And you might see those signs of the underlying cause, like a fever or trauma or a burn in those type of ARDS. All right, so how do we diagnose and work this up? So ARDS is diagnosed based on the Berlin criteria, and there are several different criteria within the criteria that we need to know. So first off is timing. So we have to have onset of the ARDS within 1 week of a known clinical insult like sepsis or trauma or a burn or whatever it is. So it has to be within 1 week of this known insult. Number two, chest imaging. So we have to have bilateral opacities on chest x-ray or CT that are not fully explained by something else like an effusion, a collapse, or nodules. Third, the respiratory failure cannot be due to a cardiac cause. So we have to rule out the cardiogenic pulmonary edema by getting a BNP and maybe some other studies. Last but not least, hypoxemia. So ARDS is defined by the PaO2 FiO2 ratio on arterial blood gas on an ABG. So mild ARDS is going to be between 200 and 300 millimeters of mercury. Moderate is going to be 100 to 200 millimeters of mercury, and severe ARDS is going to be a PaO2 to FiO2 ratio of less than 100. And this is really crucial. Now, key labs and tests, there's some other things we should consider here. An ABG, like we just mentioned, we're going to need to get that. It's going to show us hypoxemia and possibly respiratory alkalosis in the early stages. We want to get a chest x-ray. We have to get some sort of chest imaging for this Berlin criteria. It's going to show those bilateral infiltrates and an echocardiogram. And this is going to help us rule out the cardiogenic pulmonary edema in addition to the BNP. All right, so how do we manage these patients? Well, they are very, very, very sick, and there is a high mortality rate with ARDS, but there are some things we can do to try to save their lives. So one is supportive care. We want to treat the underlying cause. That is the number one thing we can do, is to treat the underlying cause. If they have sepsis, we need to give those antibiotics. If they have pneumonia, we need to give the antibiotics. We also need to give them oxygen therapy. We are aiming for a PaO2 of greater than 55 to 80 millimeters of mercury, or an SpO2 of greater than 88 to 95%. Now, these patients are going to be hypoxic, and they are hypoxic despite the oxygen we are giving them. So in most cases, we will have to provide mechanical ventilation. This mechanical ventilation, we want to use low tidal volume ventilation, and we want to prevent ventilator-induced lung injury. We also want to maintain a plateau pressure of less than or equal to 30 centimeters of water. We need to use PEEP, positive end expiratory pressure, and this is to help prevent alveolar collapse at the end of expiration. Another thing we can do to help manage our patients is place them in the prone position. So this has been shown to improve oxygenation in moderate to severe ARDS. And I'm not sure if you recall, but back when COVID was really at peak, we were seeing a lot of the patients developing ARDS from these infections, and we were seeing the ICUs filled with patients in the prone position on ventilators. Another thing that we can do is fluid management. So we have to do conservative fluid strategy so that we minimize the pulmonary edema. Remember that with sepsis, we tend to give lots and lots of fluids, but we have to be a little bit careful and strategic in fluid management with these type of patients because of that pulmonary edema. Other medications, well, there is no specific medication for ARDS. The management is really focusing on supportive care. Corticosteroids may be considered in the fibrotic phase or specific causes like COVID-19. And then ECMO, which is extracorporeal membrane oxygenation, is reserved for refractory cases in severe ARDS. So let's look quickly at the book med versus the street med. So the book med is going to be emphasizing the Berlin criteria, mechanical ventilation strategies, and oxygenation goals. And we're going to use that low tidal volume ventilation to avoid barotrauma. In street med, real life ARDS, it is often diagnosed in the context of sepsis or trauma, and the management really depends on the resources available at the hospital, right? So in a smaller hospital, limited setting, they might not have the capability to place patients in prone positioning, or it might not be feasible for extended periods of time. Instead, they might focus on shorter, more frequent position sessions and maybe more aggressive oxygenation management. And then ECMO, even though it can be life-saving in severe ARDS, is typically only available at advanced tertiary care centers, so don't delay transfer if needed. All right, clinical pearls, quick update. We have number one, ARDS is a clinical syndrome. It's not a specific disease, so look for it and treat the underlying cause. Number two, the hallmark of ARDS is hypoxemia refractory to oxygen therapy, which is what makes it so dangerous. We want to use low tidal volume ventilation to avoid further lung injury and use prone positioning if we can to improve outcomes in severe cases. All right, let's do our knowledge check here. So we have a 55-year-old male with sepsis secondary to pneumonia who develops dyspnea and hypoxia requiring mechanical ventilation. Chest x-ray shows bilateral infiltrates and an ABG reveals a PaO2 to FiO2 ratio of 150 millimeters of mercury. What is the most likely diagnosis? Is it A, cardiogenic pulmonary edema, B, acute respiratory distress syndrome, C, pulmonary embolism, or D, pneumothorax? I'll just give you a couple seconds for this one. Well, if you said B, acute respiratory distress syndrome, you have been paying attention. And the combination of sepsis, bilateral infiltrates, a PaO2 to FiO2 ratio of 150 fulfills the Berlin criteria for moderate ARDS. Now, question two, we have a 40-year-old woman with pancreatitis who is diagnosed with ARDS. She is on mechanical ventilation. What ventilation strategy is recommended to minimize lung injury? Is it A, high tidal volume and low PEEP? Is it B, low tidal volume and high PEEP? Is it C, high tidal volume and high PEEP? Or is it D, low tidal volume and low PEEP? I'll give you a few seconds. If you said B, low tidal volume and high PEEP, you are correct. Remember, low tidal volume ventilation reduces ventilator-induced lung injury, while high PEEP prevents alveolar collapse. All right, I want to thank you for joining me on this episode of the Pro PA podcast. I hope it gave you clear understanding of this critical condition and how to recognize and manage it in clinical practice. Stay tuned for the next high-yield topic as we continue to cover key pulmonary circulation and respiratory conditions. And if you found this episode helpful, follow the podcast and turn on notifications so you never miss an update. And remember, this is the Pro PA podcast, where future pros in medicine are made. I'll see you soon.